much did use those words. And so when Asim approached me about this, I thought it might be an opportunity to begin that conversation with you. And these are my objectives. I'm at an academic medical center, so I always have objectives. One of the bioethicists who has given some attention to healthcare costs is Dr. Howard Brody. He used to be at UTMB. In 2010, he came to the Texas Medical Center campus to Houston Methodist Hospital and gave a grand rounds. And I wrote this down because I thought it was such an excellent point. So he said, rationing healthcare is inevitable and is also ethical when done openly by a fair process. But the fairest system would first eliminate non-beneficial interventions before trying to ration expensive but potentially beneficial treatment. And just about this time, he published an article in the New England Journal of Medicine, and the gist of it was that within each specialty, all the physicians know that there are some interventions that are just unnecessary, are not supported by robust evidence, and are costly. And if each specialty would just identify the top 5 meeting those kinds of criteria for that specialty and work to reduce or ideally eliminate that intervention, then it could have a major impact. And this idea really took off. So it became the Choosing Wisely campaign, and as you can see from this graph, by 2016, that's 79 medical societies that had signed on to Choosing Wisely, and they've issued over 500 recommendations. So here's an example from the American Academy of Family Physicians. In fact, they liked it so well, they have a top 15 list. And at the very top of their list is don't do imaging for low back pain within the first 6 weeks unless red flags are present. And in that brief justification, they list some of the red flags. They note that there's evidence that absent red flags, this kind of imaging does not improve outcomes and it's costly. And just to give you a sense of that, there's one estimate out there just for the Medicare program alone that low-value imaging for lower back pain costs between $82 million and $225 million annually, just for the Medicare population. And that's a big range, but even if it's actually at the low end, it's a significant amount of money. And that may be a reason why this is also on the top 5 list for 4 other medical societies. But the picture isn't as rosy when you look to see what's actually happened in areas like this. So I don't know if you can see right down the middle of this graph, there's a dotted line to mark the launch of the Choosing Wisely campaign. And the top line is for high-value imaging, and it's very reassuring that that line is basically unaffected, because that's what you want, right? But when you look at low-value imaging, there's also not much movement. That's a 4% relative reduction. And if you look at specific regions of the country, in some cases it's worse. For example, in the South, it's 2.45% relative reduction. That's all. And so when I saw this, one question I asked myself is, well, I asked what's going on. But one thought I had is that Howard Brody and the leaders of the medical societies may be convinced that physicians are key players and have a role to play in reducing unnecessary treatment. But maybe the rank and file physicians don't share that view. But when I looked around, that seemed not to be the case. This was a survey done at 2 points in time. In each case, physicians look to themselves as being in the best position to address unnecessary care. So let's remove that. I just wondered if you guys have thoughts on what may be behind the evidence that practice really isn't changing very much in this area. Yes?
Maybe liability issues, so people trying to cover themselves by continuing to image, even if they know it's probably not necessary.
Very good. Liability issues. Yeah. Very important. I'm going to show you a slide in a minute. That is number 1. But there's something else too. Yes?
Well, I was just going to say, maybe it's also that patients may feel like it might be valuable even though evidence shows that it isn't.
Fantastic. So you guys have captured very quickly and concisely what seem to be the two top reasons. Because if you look, this is more data from that survey, there are two clusters. One around concerns about malpractice liability, wanting to reduce uncertainty and safety, and then the second cluster around either patient demand or patient happiness and satisfaction. And that piece has only grown as patient satisfaction has been assessed to influence remuneration of physicians. So bonuses, for example, may be contingent on high patient satisfaction. Concerning malpractice liability, there is some evidence that even if you change the laws to be more protective of physicians, practice patterns don't change. But there is a thought that maybe we could do more on the patient side. And one of the collaborators in Choosing Wisely is Consumer Reports. And so if I can manage this, they have put together a 1-minute video. Make it go away. Let me try it. I'm a technical and I have to manage to. In the video, the first question is a little ambiguous. Could something bad happen to her? If you look at the question list, it's actually specifically a question about whether the intervention or medication that's being contemplated would have risks or side effects. And the Consumer Reports research suggests that that's really, if you want to have an overuse message resonate with patients, that's what you need to stress. This is kind of brought home to me. I remembered I used to have a dryer that had a button that said extra care. And I still don't know what it did, but I always pressed it because it just seemed like extra care should be a good thing. And I think a lot of patients have that attitude. Okay, so another part of the Choosing Wisely strategy then, in partnership in some cases with Consumer Reports, is to create materials for patients that highlight the risk side of the equation. So here's one for imaging tests for lower back pain. Here's another one that has a slightly different format. And then this is another common top fiber, which is antibiotics for respiratory illnesses. Now, another possibility, if doctors who are already out there in practice are pretty set in their ways that you want to make change, is to work with trainees. So how many of you have heard of SOAP? SOAP Note. It's a pretty common way of organizing notes and presentations. And so these physicians are proposing to add a V to SOAP And the S is subjective, the O is objective, A assessments, P plan, V for value. And you can see over here that value encompasses a couple of different kinds of considerations. So is there an evidence that this will make a difference in outcomes? What about that connection or lack of connection to patient values? And finally, the cost. And because a lot of physicians actually don't know what things cost, this surprised me, but it's true. There's a link to a healthcare blue book. But thinking about especially the cost questions made me consider how the term low value care, which is often used, is really a spectrum concept. So at one end you have non-beneficial treatment, the kind of thing that Brody was referring to, where there's evidence that it doesn't make a difference in outcomes, and added to that you may have risks, and it certainly adds cost to the healthcare system. But further along on the spectrum, there are likely to be things that either we don't have very good evidence about, or that we know are cost effective in certain populations, but not cost effective in other populations. And there are some items on top 5 and top 15 lists that actually have cost effectiveness as the sole justification. And to me, that's beginning to look a lot like rationing. So I want to make that transition. Now, once upon a time, rationing wasn't entirely negative. Here, you see it at least portrayed as a community taking certain steps to ensure that everybody gets a fair share, which doesn't sound like a wholly negative thing. And yet in 1999, when Dr. Peter Ubel, another bioethicist who's addressed costs, writes his book with the subtitle, Why It's Time for Healthcare Rationing, you have not a community on the cover, but a corpse with a price tag on the toe, sending a slightly different message. Now, I don't know that Peter Ubel had anything to do with the cover art, but it certainly sends a rather grim message. But within the covers of the book, there's a lot that's of, I think, value. And one thing I really like is the way that he takes apart different definitions of rationing and then puts them together with this diagram. And if you look, like 1/2 is basically non-explicit rationing. So what do you think that's intended to capture or could capture? Yes, Asim?
Just sort of the normal decisions that physicians and patients are making.
So, yeah, non-reflective rationing, absolutely, I think that's a piece of it. There's one other kind of rationing that's non-explicit that we do all the time in the United States, and maybe we're not very reflective about it, but if you take a broad definition of rationing, it happens all the time. Rationing by, I hate people who like fish for answers, so I'll just tell you, I'm looking for ability to pay, right? And often that's when people rail against rationing as something they do over in Europe or socialized medicine, they usually don't consider or think about the way in which people in this country are routinely denied care they might benefit or even need because they lack the ability to pay. And so the broadest definition from Ubel is rationing is any mechanism allowing people to go without beneficial health care, and I added wanted. But that's pretty broad, and it helps us be mindful of the multiple ways in which people go without. Before I go to the next slide, so in 2015, Ubel wrote an article in the Hastings Center report titled, Why It's Not Time for Healthcare Rationing. And by that point, he concluded that the term rationing is so toxic that it shuts down conversation rather than prodding people to be thoughtful about these kinds of things. So this is kind of about rationing, but I want to think about it more under this broader umbrella of stewardship. Being mindful that we need to be careful because now again we're talking about potentially using mechanisms that allow people to go without beneficial treatment. And so for that, I want to suggest there are probably lots of frameworks. One that makes sense to me is to look at evidence, values, process, and creativity with an accent on community. So So in terms of relevant evidence, that's often cost effectiveness analysis. This is a simple metric, cost per year of life gained, borrowed from Eagle and his colleague. And even this simple list, I think, highlights a number of things. One is that there's a big difference, like there's a huge range here, right? From $850 to $26 million for this I think it's pronounced Guak, I'm not sure about that, for colon cancer screening. But what about the 7th or 8th? So we don't really practice maximalist healthcare even in this country. There are some lines that are drawn and we're just not reflective about them. Another thing that this brought home to me is just spending on medical care may not be the way we get the best bang from the buck. We certainly, I think, care about that, but there are also other kinds of spending that produce gains in life expectancy and quality of life that are a really good value. And spending on medical care can crowd those out. For the values piece, we usually think about justice. In terms of distributed justice, there's no consensus on a theory, even among academic bioethicists. But I think there's quite a bit of evidence that in this country, we do have broad support for a basic decent minimum. And anybody who followed the midterms, there were actually several deep red states where people voted for expansion of Medicaid. So I think that tends to support the view. Cost effectiveness analysis is at its foundation based in utilitarian philosophy. The goal is maximization. So that is one important piece of evidence, but people also in the values category care about fairness and equity, how things are distributed, which then leads me to think too of the importance of social justice and how any decision we might be contemplating would impact in a positive or negative way health disparities. Howard Brody mentioned open and fair process, and one approach that's gained a lot of attraction is called accountability for reasonableness. So it has these 4 components: that decisions and rationales are open and publicly accessible, that those rationales appeal to evidence, reasons, and principles or other values accepted as relevant, at least by all reasonable people, and that there are mechanisms for challenge and change, and then finally, some way of holding the mechanism or the people responsible for it accountable. I like the work of the feminist philosopher Iris Marion Young, and so I also add from her work that we should have meaningful participation by those affected. So looking first in the policy sphere and how this can work out, this is one of my hero organizations, the Institute for Clinical and Economic Review. And they also have their cute video. It's, I think, 4 minutes, so I don't have time to show it. But basically, they focus on evaluation, and their core work relates to pharmaceuticals, but they also branch out. For example, they have a report on imaging for lower back pain. And they are very concerned and thoughtful about value. Actually, the founder of ICER, Stephen Pearson, physician, is one of the advocates for accountability for reasonableness. And so they've built in, everything has as its goal sustainable access to high-value care for all patients. And they're very clear that they see their work as tied to eliminating rationing by ability to pay, or at least reducing it to the extent possible. And they look at short-term affordability, but the most extensive work is long-term value for money. And cost-effectiveness evidence is certainly important, but they also look at contextual considerations and other benefits or disadvantages, and those pick up, for example, the social justice piece. And then finally, they've given a lot of thought to engaging patients in public, those affected, so it's a very transparent process, and there are multiple points where they solicit input. It's a little trickier when we look at the bedside, and there's not so much, that tends not to be transparent as your comment on non-explicit rationing suggested. So we do know a little bit. This was a survey and had a fairly decent response rate for this kind of thing. And just over 50% of the physician respondents reported that they refrained from providing at least one of 10 listed interventions in the prior 6 months because of cost to the healthcare system. So there's still some room for interpretation there. The top interventions were prescription drugs, MRI, and laboratory tests, in terms of refraining from providing the things that tended not to be foregone are a range of referrals, for example, to specialists or to the ICU. One thing this survey makes clear is that those words really do matter. So if you ask if it's the physician's responsibility to exercise wise stewardship of resources, you have a significant majority either strongly or moderately agreeing with that. But if you ask about responsibility to ration, complete flip goes in the other direction. So finally, I don't know how I'm doing on time, but I just have 2 examples for creativity and community. First, I just love this because we always say think outside the box, and it's kind of a cliche. This is a $2 virtual reality headset made by Google, and it's kind of thinking outside the box by thinking inside the box or with the box. It's constructed from cardboard. But 2 examples. So this is an oldie but goodie. I actually came across this example when I was doing my dissertation research here at Rice related to managed care. And I came across the story of Dr. John Scott. He was a primary care physician at the Kaiser Permanente Clinic in Denver. And most of his patients were elderly people with 1 or more chronic conditions. And time is money, and so then, as now, there was lots of pressure from the organization to speed things up, see more patients, see patients in less time. And he really began to feel that what brought him to medicine, that didn't exist anymore. He wasn't making connections with his patients, he didn't have time to hear their stories, learn about their concerns, and so on. And so finally, he spoke up about his frustration to some colleagues. And they shared the frustration. And what could have happened is a nice little pity party, because that's often the case when we're dissatisfied. Or they could have railed against the constraints and said, change the rules, give us more resources. But they didn't do either of those things. They got together as a group, they got some support for administration. They said, how can we do this differently with the same resources? And they created this idea of a cooperative care clinic or group visit. And basically, it was a volunteer effort. So if you as a patient didn't want to do this, you didn't have to. But you would meet monthly as a group with your anchor physician, and they had an anchor nurse. And they would have topics that they were interested in, bring in speakers, and then there would always be time set aside for private visits if that was the private attention. And what happened is these groups actually became communities. Like people started sharing stories and wisdom and helping one another. They also got really attached to their primary care physician in a more a deeper way, and the nurse as well became kind of like a family member to the group, which is all very, very nice, but they didn't just leave it there with sort of feeling that yes, this was working for them. They actually did a randomized controlled trial. And the results were pretty good. So the health of these patients seemed to be pretty good, judged by them having fewer hospital admissions, ED visits, and professional services. They reported increased satisfaction and self-efficacy, and costs actually went down. So the second example is more recent and closer to home. This is an article published in April in the journal Health Affairs about an innovative experiment in Dallas. And the catalyst here was increasing emergency department use and inpatient hospitalizations for people in a really disadvantaged community in Dallas. And again, kind of rather than complain or throw up their hands, they decided what we think would make a difference is very convenient, accessible primary care, plus an approach that really focuses on social determinants of health and tries to address them. And so they partnered with Dallas Parks and Recreation Department to put a primary care clinic on site at a recreational facility, and they had all kinds of things that I think led to an enriched experience. They had a social worker who could do behavioral interventions. They had community health workers that not only went out in the community, but partnered with area congregations. This was an official food desert, and they arranged for inexpensive access to fresh fruits and vegetables and other things like that. And this wasn't randomized controlled, it was retrospective analysis, but they did decrease emergency department use and inpatient care, and they also saved a lot of money associated with that. So what I wanted to leave you with is that stewardship of resources, especially when it amounts to rationing, is ethically challenging and does involve some hard decisions, and I really haven't gone into depth with you about some of the examples, for example, in cancer care, some really expensive interventions that are coming online that are raising issues about sustainability. But there's also this opportunity, and I love the term frugal innovation, to start thinking about ways to be creative and to actually reshape healthcare in ways that I think make it more meaningful and also do more to improve population health. So that's all I have. I guess we maybe have 2 minutes for questions or something like that. So I'd be happy to answer any questions. Yes?
Do you think, perhaps it's a little too cynical, but do you think the way insurance companies pay physicians by procedure is maybe also influencing the amount of low-cost procedures that are done, or low-effectiveness procedures that are done?
I think it certainly plays a role. I think it plays a role. I think if you switch to a system where physicians are on salary, for example, the Mayo Clinic, very famous, pays the physician's salary, you're going to find different practice patterns. My guess is people actually, when they do that kind of thing, there may be a few true cynics, but I think a lot of it is just subconscious, that if I know that I make more doing this, then it'll be really easy to let those other considerations that also weigh in favor of doing more have free rein.
Do you
Yes?
think that the discussion on cost effectiveness or value changes when health is privately paid for versus systems where it's paid for by the government or by this larger network?
So yeah, I think, for example, so ICER, which I highlighted, is a private organization that works, but they're funded by insurance companies, but also foundations. If you go to the UK or to Scandinavia, they will have agencies set up that will openly consider cost effectiveness analysis. Whereas in the US, I think there's a law, for example, that was passed that said, do comparative effectiveness research, but you can't consider it when you pay for care. So the politics of it is different. I'm not sure, and whether that's private or public, I guess, sometimes private insurance companies are also painted as being sort of greedy, so I guess it can happen in both kinds of systems. But I think in our system, it is taken account of, but we try to hide it. Whereas in systems that are wholly public, but also universal, people feel more like, everybody gets a fair share. If we look at cost effectiveness along with some other things, then there's more support for it. I don't know if that answers your question exactly, but yes.
In this final example, you talked about how improving kind of community resources and things like that can reduce costs, but how do you kind of marry the fact that the cost savings will be to our healthcare system and the cost of implementing these systems will be to maybe municipalities or something? How can you connect those two?
So can you repeat that again?
So for community health, you have costs for installing recreation centers or parks, and there will be cost savings in the healthcare system. How do you incentivize the community to install these things when they won't be receiving the cost benefit?
So in this case, Baylor Scott and White knew they had the hospital that was closest to this community. They were going to see people in their emergency department and probably not get reimbursed for it because a lot of people didn't have insurance. I mean, they mentioned in the article that Texas is not a Medicaid expansion state. We have lots of people who lack insurance. So they could see rather clearly. Now, did the city, what was their incentive to just open their facility and say, we'll be a good partner? I mean, I guess one thing you could say is they've gotten some really good press out of it. Policymakers tend to read health affairs, so that was good. So there are some incentives that I think if you want to do this, you can be creative about thinking what different stakeholders could get out of this. But what you pointed to is a problem where people like go from plan to plan and aren't locked in. There are concerns that if I, through prevention, keep people from developing an illness, that may not benefit me as an insurance plan or as a health system, because they may go someplace, else, and they'll reap the benefits of that work. So I think it's time for the next speaker, but again, thank you very much.